إعلان على دكاترة.
هنبدأ دلوقتي خلاص 10 seconds وهبدأ إن شاء الله. So good evening again, everyone. I'm glad to meet you all today with a very interesting topic in the congenital heart diseases. Today is the third webinar in the congenital heart disease course at CEC, and it will be discussing ventricular septal defects in the form of a case-based discussion. I'm glad to have on board today very eminent speakers and moderators. I have Dr. Amira Noor. She is MD, PhD, MRCP. She is a lecturer of cardiology at Ain Shams University, and she is a consultant of congenital and structural heart diseases. Amira will give us a talk about the embryology and the pathophysiology of the different types of VSDs, and this will be followed by a case-based discussion. The session will be moderated today by my dear friends, Dr. Soha Rumeh, MD, PhD, FESC, FCMR. She is a consultant of adult congenital heart disease at Aswan Heart Center, and she is the director of the Advanced Cardiac Imaging Program at Aswan Heart Center. This will be also co-moderated by Dr. Hatem Hosni, FRCS, FEBCTS, and congenital and cardiac surgery. He is a consultant of cardiac surgery at Aswan Heart Center. So I hope you enjoy the session today. It's a very interesting and scientific rich session. I will stop sharing this slide now, and Dr. Amira will be ready to share her slides. So you may go, Dr. Amira.
Yes. First of all, it's an honor for me to be presenting today on the stage of CEC channel, appreciating the effort of ED's co-founder, Professor Mohammed Zahran and his colleagues. And actually, I'm glad to share my presentation today with two moderators. Actually, they are two eminent figures from Aswan Heart Center, Dr. Soha Rumeh and Dr. Hatem Hosni. But actually, before I begin, I just would like to express my sincere condolences for all the medical staff, not only in Egypt, but all over the world, who passed away, sacrificing their lives in this fight with coronavirus. And we are still appreciating the efforts of those medical staff who are still fighting it in the front lines. My talk today will be a comprehensive approach about VSD, or ventricular septal defect, and hope we will disclose all the sites and cover all its aspects. Actually, it is a basic comprehensive approach. First of all, I would like to highlight the titles that I will talk about. I will talk about the incidence of VSD, the embryology and anatomy of interventricular septum, different types and location of VSD, the pathophysiology and the hemodynamic significance of the VSD, the natural history of the patients are left untreated, and the clinical presentation. And the best workup for all those patients with VSD or their management. Actually, if we want to know the importance of any disease, we should know its incidence. I mean, how frequent is it? And actually, I think VSD is a very important topic, as VSD represented the second most common congenital heart anomaly after bicuspid aortic valve. If we consider it a congenital heart disease, it represents 20% of all congenital heart disease. And actually, if we are having 1,000 live births, at least 2 of them will have ventricular septal defect. In our lecture today, or topic today, we are talking about isolated VSD. And actually, this is the incidence of isolated VSD, but the importance of this topic, that it will help us to understand other congenital heart disease, as VSD is an integral part of many congenital cyanotic heart disease. It is an integral component, as we all know, from tetralogy of Fallot. It is associated with patient with transposition of great vessels. Actually, it is very important for the different classification of patient with double outlet right ventricle associated with truncus arteriosus. So we all know the importance of VSD. Regarding secondly, the embryology and anatomy of VSD, I will not go through the details of embryology. I just want to say that we have two parts of the interventricular septum. I mean the embryology and the anatomy of the interventricular septum, of course. From the right ventricular aspect, here this is specimen as if I am standing in the right ventricle. The embryology of the interventricular septum, we have two parts, the membranous part of the septum, and all this is the muscular part of the septum. Regarding the membranous part of the septum, it is formed from fusion of the endocardial Cushing defect with the lower part of the interatrial septum, and the muscular part of the septum, actually, it is formed from fusion of the trabecular part of the septum with the smooth inlet portion of the septum, and the fusion of the trabecular part of the septum with the smooth outlet portion of the right ventricle. So anatomically, we will divide the interventricular septum into four parts. First of all, the membranous, again, the membranous part of the septum, the inlet portion of the septum, the trabecular portion of the septum, and the outlet portion of the septum. And again, I stress on that this is from the right ventricular view. Actually, the membranous part of the septum, it is this, if we use a torch from the left ventricle and we eliminate it, only the eliminating transparent part will be the membranous part of the septum, which is the area bounded inferiorly by the septal and anterior leaflet of the tricuspid valve, and superiorly, if we remove this part, we will find the right and the non-coronary cusp of the aortic valve. The inlet is smooth portion, which starts from the annulus just below the annulus of the tricuspid valve till the start of the trabeculation, and then the outlet portion above the medial papillary muscle of the tricuspid valve. So these are the anatomical division of the interventricular septum, and accordingly, we will have the most common or the most known nomenclature of VSDs. We all know that there are different nomenclature of VSDs. I think if we are having participants here or our viewers, there may be, we all know about perimembranous subaortic VSD or paramembranous VSD, infracrystal, supracrystal, inlet muscular. So we have different nomenclature, but I think the most common classification that is well known for most of cardiologists and cardiac surgeons, these four types according to the different anatomical classification or the anatomical classification of interventricular septum. Again, if we are having a defect in the membranous part of the septum, then it is called a perimembranous VSD, and the defect in the inlet portion of the septum, it is an inlet VSD. Defect in the trabecular part of the septum, it is a muscular VSD, and a defect in the outlet portion of the septum, it is a subarterial VSD. I would like to hear from Dr. Hatem Hosni if he could tell us what are the surgical or the anatomical landmarks that can let us how to differentiate between these different types.
Thank you, Dr. Amira. So very nice description of the septum and the VSD. The VSD, as Amira said, is a really important topic, quite common and heavily involved in most of the congenital disease. So we like to describe the ventricular septal defect from the point of view of the right ventricle. So we look into the septum, the ventricular septum from the right side. And so from the right side, we notice two valves, which is the tricuspid valve and the pulmonary valve. And immediately behind the septum is the aortic valve.
Yes.
And so we like to describe the VSD in relation to the valves. So if a ventricular septal defect has a part of the edge of the defect reaching the tricuspid annulus and aortic annulus, we call that a perimembranous VSD. On the other hand, if a part of the edge of the defect reaches the pulmonary annulus and aortic annulus, we call that subarterial VSD.
Yes.
If the VSD only reaches the tricuspid valve, I mean the AV valve, and doesn't go into any semilunar valve, this is the inlet VSD. The other common name of the inlet VSD is the AV canal type VSD. So this is the classic inlet VSD that occurs in the AV canal. On the other hand, if the VSD does not reach any valve, even if it is close to one of the valve, but does not reach the annulus, still separated by muscle, and so this VSD will be surrounded by muscle all around, then we call that a muscular VSD. So we only have 4 types of VSDs.
Yes.
So in relation to valves, if the VSD reaches tricuspid and aortic annulus, it's a perimembranous.
Yes.
Pulmonary and aortic annulus is subarterial. Only tricuspid or AV valve annulus is inlet. And if it doesn't reach any valve annulus, then we call that a muscular VSD.
Yes.
So this classification does have a clinical importance. It's not just academic, because depending on the type of the VSD, some types will be closed by surgery, some will be closed by cath. Some actually have commonly closing by themselves, so spontaneous closure. Even if you close them by surgery, the approach will be very different if it is an inlet VSD than the subarterial VSD. So you approach them surgically in different ways. Different types of VSDs have a very strong correlation with conduction tissue, which is obviously an important thing to avoid heart block. So knowing which type of VSD will guide us to where to take stitches avoiding conduction. So thank you, Amira. Yeah, thank you for
Thank you, Dr. Hatem. I just would like to stress on something, and I would like to hear it if Dr. Soha agrees with me or not. There is always misunderstanding for the location and the type of VSD. As we in a lot of echocardiographic reports, we see that they are writing subaortic VSD. We just want to stress that subaortic VSD may be more than one type of VSD. Would you like to share us, Dr. Soha? Yes.
Yeah, thank you, Amira. Really, this is quite often that we usually say in our echoes that there is subaortic VSD. Subaortic, it's a location, it's not a type. As you mentioned, you and Hatem, that we have 4 types of VSD, and subaortic is a location, but not a type. I think as you said, that in this lecture, we will learn together that subaortic VSD may be one of 3 VSDs. So yes, subaortic VSD is a location, it's not a type.
Yes, okay.
And again, as I said, just mentioning subaortic VSD does not necessarily guide us. Do we close that by surgery or cath? Because if subaortic VSD can be outlet muscular, and this potentially can be closed by cath. But if it's perimembranous or subarterial, we don't want to go too far. But I mean, there are clinical implications for that. So if someone tells me this is a subaortic VSD, I would just get an idea about where that VSD is located, but I don't get an idea about the type.
The type.
And so the implications for that, I mean, surgery versus cath. Do I approach it through the tricuspid valve or through the pulmonary valve? What's the relation to the conduction tissue? This does not guide us enough.
Yes, yes. Thank you, Dr. Hatem. Thank you, Dr. Soh. Moving to the next slide, I just want to give a hint on that we all know that the tricuspid valve annulus is slightly apically displaced than the mitral valve. And so this leads to that the membranous part of the septum is divided by the septal leaflet of the tricuspid valve into 2 parts, the AV component of the membranous septum and the interventricular component of the membranous septum. And if we are having a defect here below the septal leaflet of the tricuspid valve, mostly it will be perimembranous VSD. But if we are having a defect here, it will be a defect directly between the left ventricle and right atrium, and this is called Gerbudi defect,
which is very, very rare.
Yes. Regarding the pathophysiology of VSD, actually the VSD, this is a defect in the interventricular septum between a high pressure chamber and a low pressure chamber, which is the right ventricle, below the tricuspid valve, and this lead to increase the pulmonary blood flow, which will lead to increase the left ventricular volume overload, increasing the left ventricular end diastolic pressure. Consequently, it will increase the left atrial pressure and increases the pulmonary venous flow, and then it will increase the pulmonary artery pressure, leading later on to pulmonary vascular disease. And those patients may either develop at first they develop reversible pulmonary hypertension, and later on irreversible pulmonary hypertension. Another point in the pathophysiology of VSD, that we are most of the stroke volume here in the left ventricle is shunted to the right, and actually in a large non-restrictive VSD. So stroke volume or the cardiac output will be decreased, and those patients develop symptoms of congestive heart failure, symptoms of low cardiac output, and of course pulmonary venous congestion. Actually, the VSD can be further classified, but this classification regarding the hemodynamic significance of VSD, and this is important because it will have a remarkable clinical impact later on. We have a restrictive and non-restrictive VSD. I would like to hear from Dr. Soha if you could tell us the difference between the two VSDs.
Regarding the photos that I see on the presentation, Amira, you mean?
Yes, the presentation, yeah. The presentation and the size.
Yeah, actually, on the left side, this is the apical foreview. And the probe is towards the apex of the heart. So we see in the septum flow have more or less blue color. This means that it's going away from the probe. So it's from the left to the right. And with some turbulence on it. And that, yes. On the other view, which on the right hand, it's a parasternal long axis view, and the probe is towards the right ventricular. That's why we have the beam like a triangle. And we have a defect in the septum, and I see that the flow is going freely. It's not liaised, and yes. It has red color. That means that the flow going towards the probe, so it's from the left to the right ventricle with no trabeculization. This has any impact on the definition of restrictive and non-restrictive?
Yes, if we want to differentiate between the two types, I think the restrictive VSD, it is a small or moderate-sized VSD, mostly less than 9 to 10 millimeters. It is the high velocity VSD because it is connecting a bit from a high pressure to a low pressure ventricle, and mostly the VSD is shunting from left to right. While here we are having a large non-restrictive VSD with red flow and also a blue flow, so it is shunting bidirectional. And actually the large non-restrictive VSD, mostly the two ventricles are almost of near or equal pressures.
So if we summarize the restrictive,
yes. Would you explain that for me? So you said the main difference between a restrictive and non-restrictive VSD, that
yes.
In the restrictive VSD, there is a pressure drop. So the yes. pressure of the right ventricle is yes. less than the pressure in the left ventricle. While in the non-restrictive VSD, they are almost equal pressure.
Yes.
So if a patient has a pressure drop across a VSD of 20, so let's yes. assume that the LV pressure is 100 and yes. there's a drop of 20, would you consider that a restrictive VSD?
No, this is a very low pressure gradient. Almost the two ventricles are nearly of equal pressure. The systemic pressure here is 100 millimeter mercury, and the pressure drop is 20. So if we wanted to obtain the pulmonary artery pressure or the right ventricular pressure, it will be 80 millimeter mercury. So this is mostly a non-restrictive VSD.
I see. So you say 80 millimeter mercury of pressure in the pulmonary artery This is
Yes,
very high.
significant pulmonary hypertension.
Again,
Yes.
all the hemodynamic changes will occur, even though there is a small pressure drop. So when would you consider a pressure drop would be significant? So when would you say that this is a really restrictive VSD?
Yes, I think if it is about 60 or more than millimeter mercury, then we will have a significant pressure difference between the two ventricles, and the pulmonary artery pressure will be almost 30 millimeter mercury. I think this is, or from 20 to 30 millimeter mercury, this is a significant drop in pressure, and this goes with a small restrictive VSD.
I see. So having a peer pressure less than half the systemic or approaching third systemic, this constitutes more of a restrictive VSD. Obviously, I can imagine this has a big clinical implication from the pathophysiology, presentation, and timing of management. So I see.
Yes.
Yeah. So if I can summarize what you both said, so we have a pressure gradient of 2/3 of the systemic between the RVO and
Yes.
LV.
Yes.
Am I right?
Yes, Dr. Soha.
Okay.
I think if the pulmonary artery pressure reaches to 2/3 or more than 2/3 of the systemic arterial pressure, this is mostly goes with a non-restrictive VSD and actually pulmonary hypertension.
Yeah, exactly. So now we move into the clinical picture.
And
as you said, Amira, that the congenital heart disease.
Yes.
Yeah.
Yes,
so
Dr. Soha?
Have a scenario that.
Yes,
yeah.
yes.
Do you hear me?
Yes, I can hear you. I want to hear your clinical scenario.
So I think that VSD one of the commonest congenital heart disease. So every day that we have a neighbor or a colleague that ask us about a neonate that he's 5 days old, and by routine examination, they found premembranous VSD. It's a 3 millimeter, and the estimated pulmonary artery systolic pressure is about 80, and the VSD is shunting left to right. And the question is, what should we do?
Yes, actually, this is a neonate, so I think we should follow up his VSD because in the neonates, in the first 4 to 8 weeks, this pulmonary vascular resistance, it is still elevated, and actually, this is there is still no overflow across the pulmonary valve. And from the natural history of VSD, fortunately, up to 60% of VSD closes spontaneously, especially in the first 2 years of life. So we could follow him up if we see any signs of closure for VSD. However, the most common VSDs to close are the muscular VSD followed by the perimembranous VSD, of course, with different mechanisms. And if we follow this patient up to 3 to 6 months, and we found that he started or he is having a large non-restrictive VSD and he developed symptoms of congestive heart failure, I think this VSD should be closed. So if a neonate is having a VSD, a perimembranous VSD, either it is restrictive or non-restrictive, I think we should follow him up. If it is a restrictive, moderate-sized or small-sized VSD, maybe it will close spontaneously in the first 2 years of life. If it doesn't close and the patient started to develop symptoms of congestive heart failure, it should be closed in the first 6 months, as the mortality rate is higher if we wait more than this period.
Yeah, that's perfect. And we shouldn't be afraid from this high systolic pulmonary artery pressure in neonate that he's having 80.
No. Of course, we all know that the pulmonary vascular resistance is elevated in most of the neonates, and actually, in most of them, it will be elevated up to from 4 to 8 weeks. So by time this pulmonary artery pressure or the pulmonary vascular resistance starts to decrease, and we notice that the pressure gradient across the VSD start to decrease. So first of all, we should follow him closely by echocardiography.
And Amira, when would a patient develop Eisenmenger syndrome if he has a big VSD?
Actually, according to most of data, those patients, if they are having a large non-restrictive VSD, and they passed the first 6 months without with no incidence of mortality, mostly they will develop pulmonary hypertension after 2 to 3 years. But we should be more alert or concerned about those patients with Down syndrome, because they develop pulmonary hypertension earlier than those with large non-restrictive VSD.
So patients with large VSD develop Eisenmenger syndrome, I mean irreversible pulmonary vascular disease, a lot earlier than ASD that, like Dr. Muhammad told us last time. So he told us that patient, if they develop ASD, if they develop Eisenmenger syndrome with ASD, this usually occurs at very late 60s, in life, like 40, 50, 60s, while in the VSD can develop as early as 2 years, even earlier in the Down syndrome.
Yes.
Okay, that's a good thing to notice. I have another scenario here, quite opposite actually. What if a patient like was a 15 years old patient, and then she had she was in her school and planning to do some sports. So she was doing a routine clinical checkup before getting into a sports team.
Yes.
And then the doctor could auscultate a murmur of the VSD, had an echo, and then it showed that she had a small VSD, 2 millimeters, shunting left to right. She was otherwise asymptomatic. She was actually planning to play sports, and the left ventricle was not dilated, and the PA pressure was not high.
Yes.
What would happen to such a patient?
Yes, as you said, Dr. Hatem, this patient is asymptomatic. Her VSD is not hemodynamically significant, as her pulmonary artery pressure is within normal, and actually she is having a small restrictive VSD. Mostly her left ventricle will not be dilated. So this patient, I think we should leave her alone and just follow her up by echocardiography. And we may give her only prophylaxis against infective endocarditis, but I will discuss this topic later, because I think those patients, they have actually their life expectancy is as those who do not have VSD.
So you think this would not affect the survival? So the survival should be like the normal population, as you said.
Yes. Their life expectancy and their survival is as the normal population. Yeah.
And don't you think we should close the VSD because she's at risk of getting infective endocarditis?
No, I don't think so. The risk of infective endocarditis on those patients with native VSD is very low. It is less than 0.2%. And actually, the risk of surgery and the complication after surgery exceeds, and its mortality exceeds than if we left this patient without doing anything.
Okay, thank you.
Dr. Haid. Moving to the clinical presentation, again, the clinical presentation of the VSD varies according to the size of the defect, whether it is restrictive or non-restrictive, and the magnitude of left to right shunt. If we are having a small VSD, then mostly the patient, as Dr. Hatem told us in the scenario, it will be asymptomatic, and those can be left without closure or without treatment. And a patient with a moderate-sized VSD, especially in the neonates or infant, their most common symptoms will be recurrent chest infection, failure to thrive, poor suckling, poor weight gain. And actually, those patients with large non-restrictive VSD most commonly develop symptoms of congestive heart failure, as low cardiac output and pulmonary venous congestion as early as possible, maybe in the first 6 months of life. And also the physical examination, again, varies according to the size of VSD. A small VSD, those patients will be asymptomatic with no general symptoms. And those with large non-restrictive VSD, they will have signs of congestive heart failure and low cardiac output symptoms. And actually, regarding the local cardiac examination, and patient with a small restrictive VSD, we commonly hear a harsh, faint systolic murmur over the left lower sternal border, in addition to plus or minus systolic thrill. But I just want to note that those patients with a small restrictive VSD or closing VSD, the murmur is a little bit softer, so we can hear a soft pansystolic murmur, which is an indication for closure of the VSD. While if the VSD became non-restrictive and the pressure became equal in both ventricles, mostly the murmur markedly decreases in intensity up to it will become an inaudible murmur. And later on, the patient with a large non-restrictive VSD who left untreated, as I said before, according to the natural history, they will develop Eisenmenger syndrome with its full-blown picture in the form of central cyanosis, clopping, desaturation, exertional dyspnea, with all its complications. Actually, the workup, or I want to give a hint that every patient with VSD or congenital heart disease patient, we should go on a scheme of follow-up. We shouldn't hurry to echocardiography, but first we should do an ECG. And actually, this ECG shows only sinus tachycardia, but in patient with a large non-restrictive VSD, the ECG may shows left axis deviation, left ventricular hypertrophy, signs of dilated left atrium and enlarged P wave, followed by chest X-ray, which commonly give us an important notes about the clinical status of the patient. From this X-ray, definitely we could say that this patient is having a large hemodynamically significant VSD, as we can note that there is an increased cardiothoracic ratio, dilatation of pulmonary artery, marked increase in the bronchovascular markings, and evident pulmonary venous congestion. So we don't want to forget that ECG and chest X-ray are two very important tools in helping in diagnosis and actually assess the clinical significance of patients with congenital heart disease, especially VSD. Moving to echocardiography, which we all hurry to do in all patients with VSD. Before I start the assessment of VSD with echocardiography, I just want to stress on the most important echocardiographic views, which will let us identify the different types as I explained earlier in my presentation. How would the echocardiography help us to identify the different types of VSD? I think if we started with the parasternal long axis view, and here this pink line shows us that this is there is here a subaortic VSD. But actually from the parasternal long axis view alone, we cannot determine its type. Here its location is subaortic, so immediately you should obtain your short axis view to differentiate between, as Dr. Soha and Dr. Hatem mentioned, the three different types of VSD which are located subaortic. If it is at 11 o'clock, then it will be a perimembranous subaortic VSD. If it is located at 12 o'clock, then it is an outlet muscular VSD. If it is located at 1 o'clock, then it is a subarterial VSD. So these are two important echocardiographic views in assessment of VSD, followed by the apical four-chamber view, which will help us to identify the inlet VSD here as donated by the blue line. If it is, if the VSD is located here, then it is mostly an inlet VSD. And any VSD located in the black line, thick black line here, then it is mostly a muscular VSD. So we explained, or we said how all the types of VSD I discussed before, how we could obtain them or how we could know their types from the different echocardiographic views. Dr. Soha, do you like to add anything?
Actually, I would like to ask you, Amira, if in the long parasternal view and short axis
Yes.
views, they didn't show the inlet VSD. They didn't show it, or
Yes.
they can.
Yes.
So actually, to search about the inlet VSD, I have to get a four
the apical, yes, the apical four-chamber view. Yes.
So I might have an intact septum in the
Yes.
long parasternal view and the short axis, and still the patient have a VSD. So I have to combine both views. And the same also, if I look for the four-chamber view, I might have an intact septum because the patient have does not have a muscular or
Or an
inlet,
inlet
but he
VSD.
has a VSD in other area. He has an NV. So I have to screen the septum, as we usually said, screen the septum, but I look for the septum in the different views, as you said, the four chamber view and the long and short axis.
Yes, Dr. Sah.
Okay.
I will give just live echocardiographic examples of these types. This is the parasternal long axis view. We could appreciate here that this is a 2D defect, and on going closer to it, this is a subaortic VSD. If we obtained the short axis here, and when we obtained it, we find that it is located at 11 o'clock, so it is perimembranous subaortic VSD. And here, this is an example of the muscular VSD. We can see here a 2D defect, and actually this is a color flow here, and this is an apical muscular VSD, and also there are some small multiple apical muscular VSD, and we all know that we call it sausage cheese appearance because there are multiple apical muscular VSD. Another example here of the muscular VSD, there is an example of a small restrictive VSD, a mid-muscular VSD. And here is an example of the inlet VSD. And as Dr. Hatem mentioned earlier, we call it a canal type VSD. This is an echocardiographic apical four-chamber view of a patient with common AV canal, but this is not our issue today. But I just want you to remember that an inlet VSD is a canal type VSD. Also, this is another form of an inlet VSD here, which is related to the AV valves. And as Dr. Soha mentioned and stressed, that we should obtain the apical four-chamber view in order to identify the inlet VSD. And finally, here in this subcostal view, we could see that there is a large VSD related to both aortic and pulmonary valves. So this is a subarterial or doubly committed VSD.
Okay, this is really wonderful. Because Amira, can we go back for the inlet VSD?
Yes.
We got a question from colleagues now. They asked about the inlet VSD. So yes, this is both of them. Any one of them is clear example that we have at the back. It's the borders is the EV valve. That's why the offsetting of the tricuspid and the mitral are on the same side, and this is quite usual with the inlet VSD. Actually, this is the rule that you have the both valves at the same level. So if you have this VSD, it's inlet VSD. Yes. Sometimes this VSD could have an extension. So actually,
yes,
you see this is the inlet. No object. We will go in webinar that this is common to have. So we describe the VSD as inlet VSD as long as we see the defect in the inlet portion and the AV valves on the same side. Sometimes it have an extension to the outlet to the aorta.
Yes.
Okay.
So quickly summarizing the wonderful pictures that you have just shown. So if the VSD reaches the annulus of the AV valves, mitral and tricuspid, or if it is a common valve like the AV canal, if it truly reaches the annulus, then we call this an inlet VSD. If the VSD reaches the annulus of the aortic and tricuspid valve, that's a perimembranous VSD.
Yes.
If it reaches the annulus of aortic and pulmonary valve, this is the subarterial VSD. And if it does not reach any valve, so it's surrounded by muscle all around, this is the muscular VSD. And so we have four types: inlet, perimembranous, subarterial, and outlet. We had a question from one of our colleagues in the YouTube. So asking about, is a subarterial VSD the same as a doubly committed VSD? So we have different nomenclatures for the VSDs. So as you just mentioned, there are lots of names. So supracrystal, subarterial, doubly committed, conal VSD, outlet VSD. So these are different names. We like to to mention these four names so that we do not get confused. On the other hand, we'll discuss that later, inshallah, in the double outlet right ventricle. We have different nomenclatures there. So we say a subaortic, subpulmonic, doubly committed, and non-committed VSD. And these are actually not types of VSDs. These are locations, because in a patient with a double outlet right ventricle, which is a different topic than we have today, but the VSD is a very important feature in that. The main factor for the pathophysiology, the presentation, and the management is the location of the VSD rather than the type. So yes, a subarterial technically is a doubly committed one, where it reaches the annulus of aortic and pulmonary valves. We just don't want to confuse that with the nomenclature of the double outlet right ventricle, where we have subaortic, subpulmonic, doubly committed, non-committed. That's another topic in a different day. But
doubly committed, what does it mean? What committed to what? And doubly committed, what does it mean?
To both valves, aortic and pulmonary valves. So in normally connected heart, any VSD that opens just below the pulmonary valve will also be below the aortic valve. But if both vessels come out from the right ventricle, if a VSD is below the pulmonary, it doesn't necessarily require to be coming below the aorta. So this is a different nomenclature there. So let's just not confuse you. We have 4 types of VSDs: perimembranous, subarterial, inlet, and muscular.
Yes, I just want to stress on something, or to explain something, that we divide again the muscular VSDs or the trabecular VSDs, because we are having a large area of trabecular septum into inlet muscular, mid-muscular, and outlet muscular VSDs.
Okay. I've got another question. Oh, yeah.
Sorry. So another question, very related. Should a subarterial VSD necessarily be very large? I mean, does it necessarily be a non-restrictive VSD? So you show a really big VSD, which is subarterial, as you show on the screen now. Is that always the case, or can you have a subarterial VSD which is small?
No, you can have both cases. You can have mostly you can have a large non-restrictive subarterial VSD, or you can have a small restrictive subarterial VSDs. Both cases, we can see both them frequently.
Yes, and actually a quite common scenario that the VSD itself is actually large, but most of the defect is closed by the aortic cusp. So the residual shunt becomes quite small, becomes very restrictive, but the VSD itself is large. Obviously, as you just said, the VSD can be obviously small. This can happen, but the usual is that it's a relatively big one.
Yes, Dr. Moving to the assessment of VSD by echocardiography. These are actually the echocardiography helps us to determine, as we said, the type, the location of the VSD, and these are 2 important items with the clinical, all the clinical application or implication we discussed before. The size of VSD, and actually the number if there is more than 1 VSD. And it is very important to demonstrate the relationship of the VSD to the surrounding structure, whether it is close to the aortic valve or not, whether it is close to the tricuspid valve, is there a tricuspid valve tissue aneurysm, how close is it to the pulmonary valve, and the direction of flow, as we discussed before, is very important, whether it is shunting from left to right, or whether there is a bidirectional flow, or starting to shunt from right to left. And actually the degree of restriction of VSD across the interventricular septum, whether it is a small restrictive VSD as we discussed, or a large non-restrictive VSD. And it is very important to assess the right ventricular systolic pressure. As we all know, as an echocardiographic, we assess it indirectly using the Bernoulli equation from the tricuspid regurgitation velocity jet. It is very important to assess the right ventricular systolic pressure, and also to assess the pulmonary arterial pressure from the pulmonary regurgitant jet. And you should evaluate the hemodynamic significance of VSD, whether the left ventricle is dilated or not, the left atrium is dilated or not, and the value of the pulmonary artery pressure, and evaluate the associated lesion, and I will discuss it later. Actually, I will go through these items rapidly. As I said, you can determine the location and type of VSD by echocardiography, and its size here, it's about 2 to 3 millimeters, and the direction of flow, whether it is from left to right, or whether it is from or whether it is bidirectional or from right to left. And actually, the assessment using the continuous wave Doppler here, we can assess the pressure gradient across the VSD. Here, this patient was having a pressure gradient of about 65 millimeter mercury. And again, I want to stress on the clinical scenario Dr. Hatem asked me earlier. If we are having a VSD with a pressure gradient of 65 millimeter mercury, how can we calculate the pulmonary artery pressure? If we know that the systemic pressure of this patient is 100 millimeter mercury, and the pressure gradient across the VSD is 65 millimeter mercury, then definitely the pulmonary artery pressure, we can obtain the pulmonary artery pressure by subtracting the pressure gradient across the VSD from the systemic pressure, so it will be 35 millimeter mercury.
So pressure gradient is another way of saying
Yes.
pressure difference.
Yes.
So
yes, pressure gradient is another way to say pressure difference between the two.
difference. And can you measure pressure difference? I mean, can you measure pressure by echo?
Yes, we can measure pressure gradient by echo. As I said, we can use the continuous wave Doppler by applying the continuous wave Doppler across, but it should be perpendicular to the VSD in order to obtain an adequate or an optimum measurement or an accurate measurement. If it is directly perpendicular to it, then you can obtain the pressure gradient or the pressure drop or the pressure difference between the two ventricles. And if you know the systemic arterial pressure of this patient, then you can calculate the pulmonary artery pressure, and you can say that this pressure gradient is high, indicating that this patient is having normal pulmonary or within normal pulmonary artery pressure.
That's great, Amira. Thank you. So as you said, echo measures velocity of blood, and
Yes.
by applying the Bernoulli equation, as you just said, you
Yes.
calculate from the velocity of blood what
Yes.
is the pressure difference across this defect.
Yes.
And that's why echo cannot get the absolute pressure in any chamber. It can just measure pressure difference between two chambers. And since so we try to get the pressure difference between one chamber that we know of and then the other chamber that we don't know of. So if we know the pressure in the left ventricle is roughly equal to the aortic pressure if there is no aortic stenosis. So if we know that, we can measure systemic blood pressure, which gives an idea about the aortic pressure, which should be the same as the systolic LV pressure. And so if we got a pressure drop of 65 across the VSD, then we subtract that, and then we know that the RV pressure, which is roughly the same as the pulmonary artery systolic pressure, that will be the 100 minus 65 equals 35. So we estimate PA pressure to be roughly like 35. Is that very accurate, Amir?
No, this is, as you said, we depend on the continuous wave Doppler, and actually this is not an invasive hemodynamic assessment for the ventricular pressures. Actually, we have we can do a cardiac catheterization, which give us which is more accurate than the echocardiography. As we said, we obtain it from an indirect method, which is the Bernoulli equation through the velocity of the jet across this defect.
So if you are in doubt and you really need to know accurately the PA pressure, we measure that directly by cath, and then it would be a direct measurement rather than a calculation from echo.
Yes, Dr.
Yeah.
Thank you.
Amira, could we go back to the previous
yes
file?
This one?
So we might have a VSD that pressure gradient is 65,
Yes.
But the systolic pressure in that adult patient, it's 130. Does it have any implication on the calculation of pulmonary artery pressure?
Yes, the pulmonary artery
If we
pressure,
have the same pressure gradient?
and we have the same pressure gradient, then the pulmonary artery pressure mostly will be 65 millimeter mercury, and this is definitely elevated pulmonary artery pressure and an indication for pulmonary hypertension. But still 65 is exactly half the systemic arterial blood pressure. So maybe if we made a hemodynamic assessment for we need to do a hemodynamic assessment for more accurate assessment of the pressures, but definitely his pulmonary artery pressure is elevated.
So it might be useful tip for our colleagues who do an echo for VSD to measure the systemic systemic pressure. I mean, just a simple non-invasive measurement and report it in the echo report.
So yeah, that's an important parameter, because if we know that the pressure gradient across the VSD is 65, while the arterial pressure was 90, this is a very different thing than if the systemic pressure was 140. So this can have a lot of different applications. So it's a good practice when reporting echo and measuring gradient to also report on the echo that while doing the echo, the systemic blood pressure was so and so.
Yes.
And we mean the systemic blood pressure is just the normal blood pressure measurement. It's not, it's not sophisticated thing.
Yes.
Yeah.
Moving to the next slide, as I said, the assessment of the hemodynamic significance of VSD is very important. We should assess the left ventricular dimension, the left atrial dimension, and here this was a patient who was 3 years old, and actually his left ventricular end diastolic diameter was increased, so this left ventricle was dilated. And again, I said we should assess the relation of the defect to the neighboring structure, and here we could see that this VSD is very close to the aortic valve, which could give us an implication that this should be closed surgically, and it may be also important for the cardiac surgeon if we know that the VSD is very close to the aortic valve. So assessment of the relation of VSD to the neighboring structure is very important. To summarize, if you are writing an echocardiographic report about VSD, you should answer all this question, or you should put this question in your mind. The type and location of VSD, whether it is restrictive or not, whether the left ventricle and left atrium are dilated or not, what is the pulmonary artery pressure. As we said, you should scan the septum in order to know are there any other VSD, as one of the common scenarios that we can see if you are having a large non-restrictive VSD, and actually it may attract the echocardiographer view, and he concentrate on this large VSD. And in most large non-restrictive VSD, the pressure is equal in both ventricle. So if the patient is having a small muscular VSD or a small apical muscular VSD, there will no color flow aliasing due to the equalization of pressure in both ventricle. So it is very important to scan the septum and to look for a 2D defect. And there is a color flow defect across it or not, so as not to miss any VSD. Regarding the association of VSDs, I will discuss it in the next slide. Actually,
Amira, we got a question. We got a question from our colleagues on the YouTube on could you explain how do you find the dilated left ventricle in the clinical practice? Which method you prefer? Is it linear or Samson's, or how do you define that left ventricle is dilated?
Yes, actually, we use the echocardiography for assessment of dilatation of left ventricle. We have what is called the Z score. We have certain limits or certain range according to the weight of the patient. So if the left ventricular dimensions, we measure it as I showed here. We measured it by M mode. We measured the left ventricular in diastolic and the left ventricular in systolic. So if it is more than the range for this patient according to his weight, So we consider that the left ventricle is dilated.
Yeah, the linear method is the most practical one, I think.
Yes.
And for the children, we might have a reference from the Z-score for the body surface area. This is
regarding associated defects with VSD, VSD could be associated with ASD, so the sequential echo-segmental analysis is very important, that you should scan that the patient does not have any other defects. ASD may be associated, he may have an associated pulmonary stenosis, he may have an associated patent ductus arteriosus, and this sometimes commonly missed in patients with large non-restrictive VSD and who started to develop pulmonary hypertension. Actually, there will be no pressure difference between the aorta and the pulmonary artery, so we could not note the flow of the PDA. Dr. Hatem, can you tell us how can we solve this dilemma? Commonly, if the patient is having pulmonary hypertension, we cannot exclude is there a PDA or not.
Actually, nice question. So quite challenging. If you have a big VSD, so this means that there's equalization of pressure. As you said, unrestricted VSD means that there will be equalization of pressures of LV and RV. So the RV pressure will be equal to the systemic. So the pulmonary artery pressure will be equal to the systemic.
Yes.
And then we mostly diagnose PDE, and as you quite rightly said, other VSDs by echo, by detecting flow across these. So if you can detect a flow across PDA by echo, then you say that there is an PDA. And if you can detect flow across the septum, then you can say that this is another VSD, in addition to the big one that we can see easily.
Yes.
In case there is a large VSD, there will be equalization of pressure. And if there is equalization of pressure, there will not be enough flow across other structures. I mean, there will not be enough flow across the PDA for the echo to detect. Although there is a physical significant PDA, but we cannot detect flow across it because the pressure in the aorta is roughly equal to the pressure in the pulmonary. And so there is no flow across that. And so people can easily miss the presence of a PDA in the presence of a large VSD. Practically, what we do in surgery is that if a patient is going for surgery for a large VSD, unrestricted VSD, we just ligate the PDA, regardless if it is open or not, because we cannot exclude that by echo.
Yes.
Okay? So we know the site of the PDA, it's a single PDA, we just go for that and we close it routinely, regardless if we could detect flow or not. The problem occurs with the VSDs, because as you showed in the initial specimen view showing the right ventricular side of the septum, there are lots of coarse trabeculations. And any of these trabeculations can hide the large VSD, the one we're going after. But if there are other VSDs, like 4, 5, 6 other VSDs in the muscular septum, we can easily, and it's not like the PDA where we just look into that and just close if you find, because we can stay like half an hour or more looking for VSDs and we're not sure if there are VSDs or not, because the right ventricular side of the septum is very heavily trabeculated by coarse trabeculations, which can hide VSDs. And so the hint here is that we have to very carefully look for other VSDs, but you just said that we can miss VSDs because there is no flow across it. So we do not depend on color flow. We actually look by 2D, and you screen the septum very well by 2D in different views, looking for an actual defect that we can see by 2D, not necessarily passes flow of blood.
Yes.
Because otherwise, when you close the big VSD, there will be significant other VSDs that we missed, and which we don't want to do.
Yes. Oh, thank you, Dr. Hatem. And also,
Hatem and Amira, about the BDA, I would like to have your comment on sometimes in echocardiographic, I read instead of no BDA in non-restrictive VSD, I read a comment that BDA couldn't exclude it, or do you think that we should do that in the non-restrictive VSD?
I think you first, before writing this, you should screen, or you should search for the PDA meticulously, whether there is a 2D defect, whether you are suspecting it or not. But I think if there is a pulmonary hypertension, you cannot exclude if there is not a PDA or not. Yes. Coarctation is also a common association with VSD. Dr. Hatem, do the approach differ if we are having the surgical approach differ if we are having VSD and aortic coarctation? And I want just to stress on all the echocardiographic that echocardiographer that they shouldn't miss the suprasternal view to ensure that there is aortic coarctation or not, because it is a common association with VSD.
Indeed, coarctation is a common association with VSD. Some of that might be related to flow theory, where less blood went into the aortic arch during fetal life because of the VSD itself. So yes, coarctation is a common association. Does that affect the management? Yes. There are different views here. So, some might advocate to correct the coarctation first, maybe from a thoracotomy, and do pulmonary artery band, and then do a later VSD closure. One other approach is that you do the coarctation again from a thoracotomy, and then during the same session or the second day during the same hospitalization, you do the VSD closure without doing a band first. A third approach, which we actually prefer, is that you correct both from a median sternotomy. So we go from a median sternotomy on bypass, you close the VSD, and you repair the aortic coarctation, which is obviously not a small operation. But there are different views for that. So yes, the present coarctation does affect management, and there are different schools for doing that.
Yes, thank you, Dr. Hatem. Another common, not common, but an associated finding with VSD, and mostly we can find it in teenager, which is a double-chambered RV. And actually, it is found in 10% of adult patient or teenager with VSD, as the jet from the left ventricle to the right ventricle hits into the right ventricular free wall, and this leads to a compensatory mechanism with hypertrophy of the muscle band, forming a circular muscle band and dividing the right ventricle into a low pressure chamber below the circular muscle band and a high pressure chamber above it. And this decreases the gradient across the VSD. And actually, it is a protective mechanism, and it protects the pulmonary artery from overflow of VSD, but it should be surgically corrected, of course, maybe do resection of the muscle band and then closes the VSD. And here these two, this modified suprasternal, this modified short axis view can show us here that there is this is a perimembranous subaortic VSD, and here there is a color flow aliasing across a second hypertrophied muscle band, and here is the pulmonary valve.
Sorry, Amira, just to ask you here.
Yes.
A double-chambered right ventricle, is that different from double-outlet right ventricle, or are they the same?
No, of course, that is different. Double-chambered right ventricle, as we said, it is an association with VSD. And we mean by double-chambered that there is a development of a muscle band which divides the right ventricle into two chambers, a low-pressure chamber and a high-pressure chamber. But double outlet
is another way of saying that it's severe subvalvular pulmonary obstruction.
Yes,
and
or mid or
very, very different than the double outlet right ventricle, which is a totally separate disease.
Yes.
Thank you.
Thank you, Dr. Hatem. Another important associated defect or finding that we must look for in the echocardiography, and it is very commonly seen in patients with subarterial and perimembranous subaortic VSD, and you should exclude it that you are having a cusp prolapse of the aortic valve, and we commonly see it with the right coronary cusp and the non-coronary cusp. And actually, the importance of this issue when you have a cusp prolapse, actually it closes the large VSD, as Dr. Hatem said. If it was a subarterial VSD, which commonly occurs with a subarterial VSD, then the cusp will close the VSD, decreasing the flow across it and decreasing the shunt across it and decrease the pulmonary artery flow. Some physicians or some physicians or doctors may tell the patient that he can follow up as he is having a small restrictive VSD and he is asymptomatic and it has no hemodynamic significance. But actually, this cusp prolapse, even if there is no degree of an aortic regurgitation, it causes secondary changes of the aortic valve. I think, and I want to listen also from Dr. Soha, if the patient is having an aortic cusp prolapse without any degree of aortic regurgitation, should he close the VSD or should he follow up?
Well, the dilemma of the aorta with the VSD. Okay, it depends on several things. First of all, the age of the patient.
Yeah.
So to make things simple, in children, we will keep close follow-up, and close follow-up means it's to have an echo instead of each year, to have an echo every 6 months. And actually, with any degree of aortic regurg, travel less than mild, we will go for surgery, not because we are worried about the VSD and the hemodynamics, but to protect the aorta. So we wouldn't like to have a child who will go for VSD closure and repair of the aorta later on. So to protect the aortic valve, we will close the VSD to have a native good aortic valve in children.
Yes.
Shall I tell you a story here?
Yeah.
So a patient presents 6 months of age, some auscultation of some murmur of the VSD. Echo showed subarterial VSD, restrictive flow across it, the cusp prolapse of the aortic valve. There's no aortic regurg and a very limited flow across the VSD. Most of the VSD is closed by the cusp prolapse. So everybody is happy. So the doctor says, this is a very small VSD. Most VSDs that are not hemodynamically significant will do nothing for the patient. And the aortic valve is good. So we just follow up. The patient comes back when he is 2 years of age. Still, the VSD flow is restrictive. So the PA pressure is low, 30. There's now a moderate aortic regurg. The patient is asymptomatic. PA pressure is low. The LV is not dilated. So the doctor says, okay, the VSD is not indicated. The VSD is restricted. The aortic valve is not indicated. It is still moderate aortic regurg, so there is no indication for surgery here. So we just follow up. Now the patient comes at 4 years of age. He has severe aortic regurg. VSD is still very restrictive.
Yes.
But now he is symptomatic and the left ventricle is dilated, not because of the VSD, because of the severe aortic regurg.
Yes.
Now we have a baby, 4 years of age, who needs to replace the aortic valve. This is a really big problem. Without going into much details on that, repair of the aortic valve after severe aortic regurg with the secondary changes that occur over 4 years, this is quite difficult to repair. And if we plan to replace that valve in a child, replacing aortic valve in a child is a really, really big thing. probably it's done by the Ross procedure. But actually, one thing to notice here that the Ross procedure most probably is not feasible with subarterial VSD because there is no conus to take the pulmonary valve. So now we have a huge problem for a very simple disease. Patients with aortic cusp prolapse should have the VSD closed regardless of the indication for surgery for the aortic valve. We do not wait for the aortic regurg to be moderate or severe to close this. Any degree of aortic regurg with cusp prolapse, we should close the VSD. VSD closure is a really simple procedure. Ross procedure, and even not able to do it, that's a really, really big thing.
Yes. Thank you, Dr. Hatem. Thank you, Dr. Soha. Another common association we might find with VSD, and we should look for it closely, is a subaortic membrane and sometimes a subvalvular aortic stenosis. And here this is a transesophageal echo showing that the patient is having a subaortic membrane, and also he is having a cusp prolapse. The right coronary cusp is prolapsing and closing the VSD. So all of these are common association, and you should look for it and exclude it in your echocardiography or while you are doing your echocardiography. Just another associated finding we might find it with the inlet VSD, and actually it is very important to stress on it here because we will not discuss it in any of our session or any of our coming session in congenital heart disease, which is the overriding and the straddling of the AV valves, which commonly seen or which occurs with the inlet VSD. Actually, the overriding or straddling of the AV valves, it is one form of the atrioventricular alignment or connection. I mean, if you say that the patient is AV concordant or AV discordant, also the overriding and the overriding of the AV valve is one of these atrioventricular alignments. Here we can see that the patient is having an overriding tricuspid valve, and this means, or overriding means that the annulus of the valve is, there is an inlet VSD and the annulus of the valve is overriding the interventricular septum. And actually the degree of overriding is of utmost importance here, because if you are having an overriding less than 50%, then mostly you are having two ventricles of comparable size, and the patient can close the VSD and having a biventricular repair. But if you are having an overriding AV valve which is more than 50%, then mostly the contralateral ventricle will be rudimentary or smaller in size due to decrease the blood flow to this ventricle, and actually he may be not candidate for a biventricular repair. Another title or another issue we want to discuss here is the straddling of the AV valve, and actually the straddling is related to the subvalvular apparatus, either the chordae or the papillary muscle, which is attachment of the chordae or papillary muscle of the AV valve to the contralateral ventricle, either to the interventricular septum or to the free wall. And actually also the straddling is a very important or has a very important clinical implication. You should mention it in your echo if you are having an inlet VSD, as sometimes I think it makes the repair of VSD difficult, and I would like to ask Dr. Hatem if you're having an overriding or straddling tricuspid valve, would the repair of VSD be easy, or it will be a difficult procedure?
So this is a challenging scenario. So straddling means one of the cords, one or more of the cords, crosses the VSD and gets attached to the other ventricle. And so having to close the VSD, technically we need to cross these cords. Technically, we have to cut them to be able to separate both ventricles. So it depends. At first, we have to look to make sure that both ventricles are of adequate size, as you just said, that the overriding is not too much. We don't go into the spectrum of a double inlet ventricle. So both ventricles have good size to support each circulation. But then we now have to consider the crossing cords. are we able to sacrifice that and either repair the valve? So sometimes if it's a single or two cords that we can detach from the other ventricle, close the VSD, and then reattach them into the patch, or maybe put artificial cords, we can do that. But sometimes the valve is attached to a big papillary muscle into the other side of the ventricle, and a large portion of the valve depends on that papillary muscle. So if you cut that, you virtually destroy that valve. Destroying a mitral or a tricuspid valve is not tolerated at all in small kids. So unfortunately, although these patients have two good ventricles, we may not be able to separate the circulation. And so sadly, they go to a single ventricle pathway rather than destroying a valve just to be able to do a two ventricle repair here.
Yes, Dr. Hatem. And I want to just give an examples of the overriding and the straddling, just to ensure their importance and how you should comment on them on echo. Here we are having an inlet VSD, and as Dr. Soha said, both AV valves are on the same level, and we can see here that the tricuspid valve is overriding the interventricular septum, but I think it is still less than 50%, and we are having two ventricles of comparable size. And also this is a subcostal view where we can see here also the overriding, but we can not see here that one of the chordae of the tricuspid valve is attached to maybe to the cross or to the to a part of the interventricular septum. However, I think, as Dr. Hatem said, this could be repaired, and this is only one chordae of the tricuspid valve. However, I think this is the scenario that you discussed, Dr. Hatem, when there is a large chordae, mostly with a papillary muscle here attached to the contralateral ventricle, then the repair might be quite difficult, or as you said, we can go to univentricular repair in such cases. However, I think it's rare. Do you think that, Dr. Soha? Is this common?
Fortunately not. VSD is a simple disease, and when it's complicated with such stuff, it is a complicated VSD, which is fortunately uncommon. But as you said, Amira, with each inlet VSD, you have to look carefully for that. Yes. As Hatem said, this might dramatically change the fate of this patient. But I would like to ask you, Amira, overriding is a thing and the straddling is another thing. So overriding, we described the annulus, and with the straddling, it is another terminology.
Yes.
Describing the subapparatus, and you agree?
Yes, I agree.
So technically, you cannot have straddling in aortic and pulmonary valves because there are no cords there, but obviously you can get overriding. In mitral and tricuspid valve, you can get overriding or straddling or both. These are two different things.
Yep. Exactly.
Also, we can notice from your talk here that straddling can be associated with inlet VSDs. So in any inlet VSD, you have to look for straddling.
Yes.
On the other hand, aortic cusp prolapse is more common with subarterial VSD. So types of VSDs can also point to common associations to each.
Yes.
A quick question from our colleague to you, and then that with quick answer. Is all restrictive VSD a small VSD? So any restrictive VSD should be a small VSD?
No, I said that restrictive VSDs could be small-sized or moderate-sized VSD. However, it is commonly less than 9 to 10 millimeters. So it could be small-sized or it could be moderate-sized. And again, we said restrictive. It depends on the difference in pressure between the two ventricles. If we are having a significant pressure between the two ventricles and the pulmonary artery pressure is within normal, then this goes with a restrictive VSD.
So a tricky question, huh? So restrictive is physiology, while small is anatomy. So as you quite clearly said, most restrictive VSDs are actually small, But VSD can be restricted by something else other than the borders, can be restricted by the aortic cusp prolapse, can be restricted by a trabeculation of the right ventricle, which restricts flow, although the VSD itself is big. So these are commonly the scenario, but yes, VSD can be restricted by something else. Another quick question, patient neonate with VSD, but with dilated right side, not left side. How would you explain that?
A patient was what?
A neonate.
Yes, a neonate. Yes.
And the right side is dilated, not the left.
Yes.
How would you explain that?
Yes, a neonate with a VSD and his right side is dilated. Mostly, this patient is having a large non-restrictive VSD and with an elevated pulmonary artery pressure or pulmonary hypertension, and this might explain that his right ventricle is dilated. But you should search for other defects. As I said, this patient may be having a large ASD, which is causing his dilated right ventricle, and you missed it.
So can be an ASD, can be, as Mahmoud Shahata, our colleagues pointed, anomalous pulmonary veins, either partial or total anomalous veins, and can simply be just the pulmonary hypertension of the newborn. So the right ventricles of the neonates are normally bigger than in adults, but in proportion, I mean. But large VSD should not necessarily get large right sides, probably large left side, dilated, I mean left side. Thank you. Sorry, Amira.
Thank you, Dr. Hatem. Thank you, Dr. Saha. Again, I just want to summarize after we finish the part of the echocardiography. You should ask yourself the following question. What is the type and location of VSD? Is it restrictive or not? Dimensions of left atrium and left ventricle, pulmonary artery pressure. Scan the septum for other VSDs. You should exclude other associated defect, or as we explained, the common association with the different types of VSD. I will just go rapidly through the role of transesophageal echo. It is as the role of the echocardiography in order also to see the associated effect of VSD, and actually it can help us commonly if there is we can see those patients with cusp prolapse of the aortic valve. We can determine it accurately using the transesophageal echo, which cusp is prolapsing. And sometimes, and as I discussed before, in patients with VSD and double chambered RV, commonly they are adults, and sometimes we couldn't visualize the double chambered RV properly from the parasternal or subcostal view. So transesophageal echo has a very important role in this associated defect. And actually, that transesophageal echo has a very important role either intra-procedure during VSD closure to ensure that there is no residual defect, and also intra-procedural during percutaneous VSD closure to ensure that the device is in its place and there is no residual defect. My question here is, does the CMR or cardiac MRI have a role in VSD? I would like to hear this answer from you, Dr. Soha.
Okay. Thank you, Amira. For the MRI, it is a fancy imaging modality and starting to be available everywhere. I would like people to use the MRI more frequently. It's non-invasive and safe, but we have to ask ourselves what we will gain, which information we will gain from MRI, and what is the limitation of MRI. As Amira shows us now, this is a simple diagram that we imagine the port chamber of the heart, and the aorta is coming of the LV and pulmonary coming out of the RV, and we have an E and VSD shunting left to right. We have it like an A, and all the blood in the each chamber is X. So usually what goes in the left ventricle goes outside from the right ventricle. So you have X in the left atrium, X in the left ventricle, X amount in the aorta that will go to superior vena cava and inferior vena cava to the right atrium. It is X, and in the right ventricle it's X, and in the pulmonary artery it's X. That's what happens normally. Back to what MRI can offer us. It's the gold standard for the volume and the flow. So yes. MRI can measure the volumes of each chamber accurately and
Yes.
can measure the flow accurately. But MRI until now are not able to measure pressure. So we're starting to build up what MRI can offer and what didn't offer. So offer volumes and offer flow.
Yes.
So when you have a doubt about your VSD, is it significant, hemodynamic significant, as Amira amazingly showed us, that the dilatation of the ventricles and the flow. So if you have a doubt about that, you might consider the MRI as additional imaging modality to the echo to provide you by the volumes of the ventricle, the left ventricle and the right in each chamber, and to provide you by the ratio between the pulmonary artery flow and aortic flow.
Yes.
What we call it QPQS. The QP is quantitative pulmonary flow, and the QS is quantitative systemic. It's the aortic flow. So we have the ratio between the aorta, between the pulmonary and the aorta. And if this ratio is more than 1.5,
Yes.
this means that the pulmonary circulation receive more, receive 1.5 more than the systemic. So this is significantly hemodynamic left to right shunt. So
Yes.
I will preserve the MRI only for the question about is it hemodynamically significantly or not. Before
Yes.
going to explain how I do that, I should say that if the question is what is the pulmonary artery pressure is, or what is the pulmonary vascular resistance is. So MRI has no role in that. We couldn't measure pressure or estimate pressure by MRI. It's underestimated. We will go maybe in another session why it's underestimated. You can have figure. This figure is not accurate. It's underestimated. So if the question is the pulmonary artery pressure or the pulmonary vascular resistance and the QPQS, you might consider the CAF as your imaging modality, not the MRI. If the pressures and the pulmonary vascular resistance is not a question, so you go for the MRI. How can we do that? This is a quite nice game. I would like always to play with it in the shunt. So if you consider the shunt, the VSD like an extra amount, it's A, the yellow A.
Yes.
And as Amira said, despite it's left to right shunt, but has no effect on the right ventricle because the shunt is only during systole, it's not during diastole. So the blood has no enough time to dilate the right ventricle. It will go immediately to the pulmonary. So we see here that XA in the pulmonary. So we have an extra amount in the pulmonary artery that will go to the pulmonary veins and going back to the left atrium. So left atrium will be dilated because it's receiving XA amount that it will go to the left ventricle during diastole. So have all the time to dilate the left ventricle. So the dimension of the left ventricle and the stroke volume of the left ventricle will be dilated. And during systole, A will go to the right ventricle, aorta will receive only X, which will go to the superior vena cava and inferior vena cava. It in the right atrium, it's X, and in the right ventricle, X, and the A will join the X in the pulmonary artery XA.
Yes.
This is I would recommend this diagram in each shunt that you have. It is very easy to understand.
Yes.
So at the end we have here XA in the pulmonary comparing to X only in the aorta. This means that the pulmonary flow QP is more than systemic flow. So the ratio is more than 1. If it's more than 1.5, it's hemodynamically significant.
Yes.
For the volume, you notice here that in diastolic volume in the left ventricle will be increased. Stroke volume will get it by subtraction of in-systole and in-diastole volumes. It will be larger than the RV. So actually, this is the 2 points that MRI can accurately offer us: the volumes and the flow. Again, MRI has no role in the pressure measurement or the resistance measurement.
Yes.
Thank you, Amira.
Yes, thank you, Dr. Saw. I think this diagram explains the most common question, why the VSD causes enlargement of the left side, despite it is a left to right shunt as the ASD, and the ASD causes dilatation of the right side. So this diagram quietly explains why the VSD causes only dilatation, or at first dilatation, of the left side of the heart. And as you said, Dr. Soha, for proper assessment of pressures or invasive pressure assessment, we should go for cardiac catheterization. And actually, the cardiac catheterization has a diagnostic role or hemodynamic role, or hemodynamic assessment role, and a therapeutic role. Yes,
Yeah.
Dr. Pat, yes.
Sorry, so before leaving cross imaging, we had two questions here. One question asking, can a CT help in detecting PDA, since the echo might be not able to exclude that? Maybe Soha can guide us. And also another question asking about, can also CT or MRI help us finding other VSDs?
Okay, I will start with the second question about the MRI and CT. Both of them are cross-imaging modalities that widely used nowadays. To detect a hidden VSD, I think that hidden VSD means that the additional VSDs, the small muscular VSD. I still stress that echo, especially in children, in good hands or in a meticulous way, will show us the 2D defects in that, and people should invest time in that. But when the question is it CT or MRI, so CT is better than the MRI in visualization of additional VSDs because of higher spatial resolution. Spatial resolution means that we could differentiate between 2 points at smaller distance than MRI can do. So for visualization of additional VSDs, we will do a CT if echo didn't help us, with a lot of highlighting of the radiation dose, because CT, it is a non-invasive modality, but with radiation dose. So we have to do our best to decrease the radiation dose for our patients. For the first question, on clinical practice, if I have restrictive VSD, I will write it is BDA couldn't be excluded, and I leave it for the surgeon just to close the BDA. I wouldn't send the patient for a CT to exclude a BDA if the patient will go for surgical closure of the VSD. It might be a different scenario if the VSD is non-restrictive and I'm searching for a reason for that hemodynamics. So I might do a CT for that, but it's not clinical practice to do a CT for each patient with non-restrictive VSD just to exclude the BDA. Do you agree with that, Hat?
Yes, agree. So to summarize, yes, CT can detect a PDA, can detect other VSDs. We would not normally use that unless we do the CT for other cause. So if we're doubting the arch and we want to look for the arch, and then we look by the way, but we would not normally do a CT specifically to detect a PDA or another VSD. Thank you,
Yeah.
so. Thank you, Amir.
Yeah.
Thank you, Dr. Haid. Moving to the role of cardiac catheterization in assessment of VSD, as Dr. So said, we have a diagnostic role and therapeutic role. We will just discuss the diagnostic role now. It is very accurate in assessment of for invasive assessment of pressure, as in those patients with large non-restrictive VSD, and they started to develop pulmonary hypertension. So we should accurately know the pulmonary artery pressure, the pulmonary vascular resistance, the QP over QS, and whether they are still candidate for surgical closure or not. And actually, we do this hemodynamic assessment of VSD, and using, I just want to stress that the assessment of pulmonary artery pressure alone or invasive measurement of pulmonary artery pressure alone is not adequate, because in some patients the pulmonary artery, the pressure may still the same. However, when you use a potent vasodilator as 100% oxygen or nitric oxide, and you take your measurements and saturation a pre and post vasodilator. After the vasodilator, of course, the pulmonary flow will increase, and this will lead directly to a decrease in the pulmonary vascular resistance. As we all know, pulmonary vascular resistance or resistance equals difference in pressure over flow. So definitely the pressure may stay the same, or the pulmonary artery pressure may stay the same after vasodilator. So you should calculate the pulmonary vascular resistance, as it might significantly increase, might significantly decrease after increasing the pulmonary artery flow. And we have certain numbers. If the pulmonary vascular resistance is less than or certain values is less than 4 Woods unit, then the patient is operable and he can close the VSD safely. If it is more than 8 Woods unit, then this patient is inoperable and he might die on table. We have a gray zone from 4 to 8 Woods unit, and actually this may carry a small risk for patient for closing after closing the VSD. Regarding the management of VSD, I will discuss the management of VSD with our case, but I just want to say that we have medical treatment and transcatheter treatment and surgical treatment for VSD, and through our case we shall know how to use each one of them, or how to manage the VSD. The medical treatment can be used in the patient with VSD and congestive heart failure, as we can give them an anti-failure measure, anti-failure treatment till VSD closure, or sometimes in those patients who develop Eisenmenger syndrome, we give them some diuretics or pulmonary vasodilators as the phosphodiesterase enzyme inhibitors. Our case today is we are having a 5-year-old girl presented to our outpatient clinic with exertional dyspnea NIHA class 2. On examination, her arterial blood pressure was 120/70 millimeter mercury. Her heart rate was 90 beats per minute. Her apex was seen and felt in the left fifth intercostal space with normal heart sounds. She had, on auscultation, she had grade 3/6 harsh pain systolic murmur over the left sternal border, however not associated with thrill. Her ECG showed only normal sinus rhythm, and her chest X-ray showed increased bronchovascular markings. And her echocardiography was as follows. This was her apical 4-chamber view. We can see here a restrictive VSD, and actually this was a hemodynamically significant VSD, as her left ventricle was mildly dilated, the patient and her left atrium was dilated, the left ventricular dimensions was increased. And also this, actually the direction of this VSD was causing the patient to have also a significant tricuspid regurgitation jet. So the first question here.
So I think, Amira, now that now we kind of diagnose that we have a patient with a mid-muscular VSD, that it's hemodynamically significant and the pulmonary artery pressure is not that
yes. Yes.
So now we have a diagnosis. Does the diagnosis indicate closure? So if the diagnosis of VSD, that any patient with VSD, should we close any patient with VSD?
Yes, actually, as you said, Dr. Saw, this patient is having a restrictive mid-muscular VSD, and it is hemodynamically significant, and this patient is symptomatic. But your question is, should every patient with VSD, should we close it or not? Before I answer this question, we should know what are the indications of VSD closure. If you are having a patient with hemodynamically significant VSD and the patient is symptomatic, or any patient with symptomatic hemodynamically significant VSD with still normal pulmonary artery pressure or without evidence of pulmonary hypertension, according to the ACC guidelines, he should close the VSD. And actually, even if the patient is asymptomatic and he is having a hemodynamically significant VSD, left ventricle dilated or increase in the pulmonary artery pressure, and he is still asymptomatic, this is a class 1 indication for VSD closure. those patients with history of previous infective endocarditis, only those who caught infective endocarditis on a native VSD, they should go for surgical VSD closure, but we should not close VSD for fear of infective endocarditis. And as Dr. Hatem discussed in details, those patients with a prolapse of an cusp of aortic valve with any degree of aortic regurgitation, they should close the VSD. I would like just to add to this indication, patients with inlet VSDs or subarterial VSDs, they should close the VSD. So in our patient here, this patient, yes, this patient should close the VSD as this patient was symptomatic. She had a hemodynamically significant VSD, a hemodynamically significant restrictive VSD. So according to the guidelines, this patient should close the VSD. But not every patient with VSD should close it, as we said before, that some patient may have a small restrictive VSD, which is not hemodynamically significant, and the patient is symptomatic, and their survival or life expectancy is as equal to those as equal to the normal population. So there's no need to close the VSD.
Yeah, okay, that's clear. So indication does not equal for closure. So, and as I remember that our patient is 5 years old, so that my question is if she should close the VSD, but when?
Yes.
What about the timing?
Yes, before again I answer your question, Dr. Soha, I just want to state what is the optimum timing for VSD closure as a whole. Again, according to the size of the VSD, whether it is a small restrictive VSD or a restrictive VSD or a large non-restrictive VSD. Actually, if you are having a neonate or a newborn with a large non-restrictive VSD, we should mostly we wait, or the optimum time of closure is from 3 to 6 months. As I said before, in the first 4 to 8 weeks, the pulmonary vascular resistance is still high. There is no fear of pulmonary overflow, and they are still most of them are low birth weight. So we still need them to gain a little bit more weight. So the optimum timing is mostly after 3 months, when the VSD is starting to be significant and there is an increase in the pulmonary blood flow and there is a fear of developing of pulmonary hypertension. Up to 6 months, not after 6 months. As I said, most of them develop congestive heart failure and the mortality rate significantly increases after 6 months. So this is the optimum timing for VSD closure in those with large non-restrictive VSD. However, if the patient is having a restrictive hemodynamically significant VSD, we can wait for the age of 2 to 3 years or preschool age, as commonly we closes the ASD at 4 to 5 years. As this patient we do not fear of development of pulmonary hypertension, despite we want them to gain weight in order to be able to close it safely, either surgically, and it gives us a better chance for percutaneous closure of VSD.
In addition to the significant chance of spontaneous closure, so some VSDs can close spontaneously, especially the perimenous and the muscular VSDs.
First 2 years of life, yes, Dr.
We do not wait if the patient has aortic cusp prolapse. Then, regardless being restrictive, we just go on.
Yes. So answering your question, Dr. Soha, our patient was a 5 years old patient. She was having a restrictive hemodynamically significant VSD. Actually, and she was symptomatic. So this is the optimum timing for VSD closure for this patient.
This is great. Does she has an options? I mean, this VSD, this particular VSD, could be closed by surgery or by cath, or she has one option?
Yes, first of all, I will illustrate the different types of VSD or the different techniques for closure of different types of VSD. We can close the muscular VSD percutaneously, either it is a high muscular or basal muscular VSD or mid-muscular or apical muscular VSD. Commonly, we have a double disc device which can close the VSD safely. And actually, in certain types of perimembranous VSD also can be closed percutaneously, but with certain criteria. We just want to assess its proximity to the aortic valve. If it is very near, then mostly the disc will encroach on the aortic valve. If we are having entrapment of tricuspid valve tissue, or if it is an aneurysmatic VSD, it is very suitable for transcatheter closure. And now we are having a lot of variable devices like multi-occluder or multifunctional devices, which can close the VSD retrogradely from the aortic side without the need of forming an AV loop, which elongates the procedure and makes it difficult. However, in perimembranous VSD, sure can be closed surgically, especially if it was a large non-restrictive VSD, and in those with a small age or those at a younger age, we cannot close it percutaneously. Those from 6 months up to 1 year. Also, surgery is the only option for those with subarterial or inlet VSD. Dr. Hatem, do you want to add anything for this application?
To summarize here,
Yes.
The rule in the muscular VSD is a cath closure.
Yes.
The rule in the subarterial inlet VSD is the surgical closure.
Yes.
Mostly with the perimembranous VSD, it is a surgical closure, unless there are some criteria that allows cath closure for that. On the other hand, very rarely muscular VSD might not be suitable for cath closure if the VSD was too big for the device, and especially if the patient has another indications for surgery, and then maybe muscular VSDs can also be closed there. So muscular VSD is cath, subarterial inlet VSD is surgery, perimembranous VSD is mostly surgery, but sometimes cath.
Yes. So this patient was having a mid-muscular VSD, and actually it closes. We closed the VSD successfully through transcatheter closure, and this is an AD01 device. Here we could see that it rests quite well in the VSD with no residual flow across it.
So can you guide me? If I'm not very familiar with cath images, so are we now injecting dye into which ventricle?
Yes, this is an LO cranial view, mostly 40 or 45 degrees. It shows us, or it gives us a better imaging for VSD in relation to both the left ventricle and right ventricle. And here we are using a pigtail and injecting dye or doing left ventricular injection. And we can see here the flow from the left ventricle into the right ventricle through the VSD.
So the cath is coming retrogradely from the aorta into the left ventricle, injecting left ventricle. And
yes, here before we. Yes, here before we do the procedure, this was only diagnostic or for assessment of the size and choosing the type of VSD. And here also, but we close the VSD after making a loop. We should use a long wire, and we cross the VSD into the right ventricle and then approach and then insert or deliver the device from the right side and place it. And here, post the release injection showed no residual flow across the VSD. I just would stress that this is not the end of the story. We close the VSD and the patient is safe and it's okay. It's very important to follow up with the patient after VSD closure, either surgical or transcatheter, because to exclude any complication after the procedure. And here was the echocardiography of this patient after she closes the VSD. There was no residual flow across. We can follow the left ventricular dimension if it started to decrease or not. And in certain types of VSD, we should do an ECG after the procedure, either surgical closure or if it was a perimembranous VSD and we closed it percutaneously, because complete heart block it's not common. However, it could occur after surgical or percutaneous closure of perimembranous VSD, as it is very close to the conduction system here in this area. So following up the patient after the procedure with an ECG and echocardiography is very important.
Okay. Amira, you beautifully said that not each VSD should be closed, and we have an indication to close it. Into my mind, we have a contraindication to close VSD. It might be not safe to close a VSD.
Yes, actually, the contraindications for VSD closure, if the patient started to develop pulmonary vascular disease and or Eisenmenger syndrome, and at this point, as I said before, we should do right heart catheterization and accurate hemodynamic assessment for this patient, calculating the invasive pulmonary artery pressure and the pulmonary vascular resistance using a potent vasodilator. And if the pulmonary vascular resistance is still less than 2/3 of the systemic vascular resistance after using a vasodilator, as I said, then the patient still have an option for VSD closure. Or in other words, we have values. If it is less than 4, as I said, this patient is still candidate for closure. Above 8, this patient is inoperable and it is contraindicated. There is a contraindication for VSD closure, as actually the incidence of this is very high on table, while this patient might live with Eisenmenger syndrome for 10 to 15 years. I think they live for 30s or 40s of age. Yes, they develop they live with disability. And regarding their with a socio-economic impact, however, they can live. So if the pulmonary vascular resistance is more than its wood unit, it is contraindicated to close the VSD. And as we said again, if we are having a small non-hemodynamically significant VSD in asymptomatic patient with normal pulmonary artery pressure, they have survival as those with normal population, so we do not need to close it.
Amira, do we have to do a right heart cath for every patient before who has a VSD?
Not in every patient who has a VSD. As I said, meticulous assessment, as we said, using the echocardiography, you assess the left ventricular dimensions. You can assess the pulmonary artery pressure. If it is within normal, then the patient can, and he will close it surgically. Then he can go straight forward for surgery. But sometimes when we are going to close it percutaneously or transcatheter, since we are already in, we take invasive pulmonary artery pressure just to make sure that it is safe for him to close the VSD, not necessarily to calculate the pulmonary vascular resistance. Only those with elevated pulmonary artery pressure, either echo or with any other modality, we should do right heart catheterization before taking the decision for closure.
Because then the question here is that patient still operable or not? So I would think of criteria like clinical criteria. So if the patient has a small VSD restrictive, so there's no question about pulmonary vascular disease here. If the patient is 3, 4, 6 months of age, this is too early to develop irreversible pulmonary vascular disease. If the chest X-ray is shows a clear plethora with cardiomegaly, if the saturation of the patient is 100%, he's fully saturated. And if we do echo, we found LV dilatation with pure left to right shunt across. So we don't usually need more evidence, and the patient clinically shows signs of pulmonary overflow, so failure to thrive, recurrent chest infections. And so if all the criteria goes with high pulmonary flow, we do not need extra evidence. We just do right heart cath if we're in doubt. So if the patient is 6 years with a large VSD, he started to desaturate, the symptoms of pulmonary overflow is less than usual. There is no cardiomegaly on X-ray. Echo shows very high pulmonary pressure, but bidirectional shunt across. And then if we are in doubt, then we do a cath to make sure.
Yes, Dr. I just want to, I have a question for you, Dr. Hatem, since we are cardiologists. I always know that you prefer primary VSD closure rather than pulmonary artery bending. But I know that in certain situations or circumstances, you have to do pulmonary artery bending. So I would like to know from you, when do you sometimes have to do pulmonary artery bending?
So this was an evolving experience in the cardiac surgery, in the field of cardiac surgery. So pulmonary artery banding is simply restricting pulmonary flow without actually closing the VSD. So we just induce pulmonary stenosis by putting an artificial band around the pulmonary artery. This used to be the norm in large VSDs in young babies, and then we allow them to grow older, and then while we are protecting the pulmonary vascular bed from the high pulmonary flow, and then at a later stage, we take out the band and close the VSD.
Yes.
This has been associated with a significant morbidity, hospital stay, and costs. With evolving improvement in the field of cardiac surgery, we now prefer closing VSD primarily, so we do not do previous prior bands. So if a patient has unrestricted VSD, 3 months of age, we just close the VSD.
Yes.
So the current practice is primary VSD closure. So there are some exceptions for that. Some patients are very, very sick, so they keep they are in severe heart failure with frank infection and pneumonia and ventilation. So they are ventilated with chest infection, pneumonia, or we try medical treatment. We're not able to get them out of pneumonia. They keep getting positive cultures. We're not happy putting synthetic patches in and frankly infected patients. And so one way, if the patient is very resistant to medical therapy, is then to do a pulmonary artery band, get him out of the infection, let him grow a bit, and then we close. Yes. The other indication for pulmonary artery banding now is multiple VSDs. Yes. So if a patient has a significant multiple VSDs, and we're probably not able to close them all, if it has a 6-7 VSDs and different places in the septum, and patient is 3 kilos, this is quite challenging. So one way of doing things is that we do a pulmonary artery banding, allow the patient to grow, and we know that a lot of VSDs will close spontaneously. And then when the patient is older, then we reassess the VSDs. Some might have closed spontaneously. Some might be suitable for cath closures, and then we close the rest. So some of the VSDs can be closed surgically, some by cath, maybe even combined.
Yes, and actually, I think here comes the role of hybrid technique, where we could cooperate, Dr. Hatem. If you are having a small baby, as you said, or an infant between 6 months and 1 year, and he is having a high risk for surgery regarding cardiopulmonary bypass and cardioplegia, and he is having a large muscular VSD. However, we couldn't close it percutaneously due to the large size of the device and the sheath. We couldn't insert it in such a small baby, so we can use the hybrid technique by doing just a right ventricular. You can do just the right ventricular puncture, and we can insert our delivery sheath, put the device, and go out safely.
Yeah, so in such technique, we open the chest, we physically open the chest by sternotomy, but we do not open the heart, we do not go on bypass. We just puncture the right ventricular free wall, and then you will have access, direct access to the big mid-muscular VSD that you would have normally closed percutaneously, but since the baby is too small for the device to go through his vessels, we can do that in a hybrid. Obviously, this needs to be done in a hybrid room, essentially under fluoroscopy guidance, but also with the setup for surgery.
Yes, yes. Thank you, Dr. Hatem. Thank you. Regarding prophylaxis against infective endocarditis, there is still a large debate. I would like to hear your opinion, or to know your opinion, Dr. Soha, regarding this issue, as the guidelines not specifically, they said only we can do prophylaxis against infective endocarditis before a high risk procedure, and only patient with cyanotic congenital heart disease or patient with repaired congenital heart disease, either VSD or ASD, using a prosthetic material, percutaneous or surgical, for 6 months. But still we have those who have a VSD and we are following up them, and they may have some dental or high risk surgical procedure. So do you think that those should also receive prophylaxis against infective endocarditis?
Uh, what we see in the slide is the European Society of Cardiology guidelines in 2010, which was really a dramatic change for the effective endocarditis prophylaxis use. And according to this guidelines, as Amira said, that VSD has no evidence to have effective endocarditis prophylaxis. Because the shunt is left to right, and they are not, the patients are not actually after this table in small letters, the European Society of Cardiology mentioned that however this guideline should be taken by precautions and see how the patients will develop effective endocarditis or not. And based on our experience in Egypt as developing country, on the clinical practice, we still see many patients with VSD that they develop effective endocarditis because the cardiologists now are reluctant to describe the effective endocarditis prophylaxis protocol. So I think it's safer for our patients in our countries to keep them under the effective endocarditis protocol because of the different circumstances, different hygiene, different maneuver in our countries. So it's still debatable, but I think it's better to be safe. So personally, I do recommend it with the patient with VSD under effective endocarditis prophylaxis.
Yes, so you recommend the prophylaxis against infective endocarditis for all patients with VSDs or with left to right? Yes,
exactly.
Thank you, Dr. Soha. I just want to just giving a small hint about complication of VSD or after VSD closure. That's why you should follow up the patient after either percutaneous or surgical closure. I said that 0.2% of patients with native VSD might develop infective endocarditis. However, after surgical or transcatheter closure, you should be aware of whether there is residual VSD, whether there is missed VSDs or not. Sometimes we see a dehiscent VSD patch. So this is very important for following up a patient after surgical closure. And this is not common. However, complete heart block has an incidence of 0.5 to 3% either after surgical or percutaneous closure. And in some patients, it needs lifetime pacing. And I think Dr. Hatem, this depends mainly on the practice or of the surgeon, right? You should be aware where do you take your stitches? What is the type of VSD you are closing?
So as you said, yes, complete heart block can occur after surgical VSD closure. We try to know the type of the VSD, and then we try to avoid, because we have guides where is the relation of the conduction tissue in relation to each type. Yet there are types that are more prone to get heart block after VSD closure, like the inlet VSD, like the canal. Some patients with the CCTGA, the VSD is already more prone to get heart block. Anyway, this is a complication that we do see, and it does impact the patient because lifetime pacing is not the best thing. They can get pacemaker-induced cardiomyopathy, so we should try very hard to avoid getting this complication.
Yes, thank you, Dr. Hatem. And finally, however, it very rarely occurs if the patch was malaligned. Subaortic stenosis or subvalvular aortic stenosis may occur. So this is, again, I stress on following up patient after surgical or percutaneous closure to detect any complication. However, inshallah, it should be avoided. Finally, my take-home message from this lecture to all of our participants today is that isolated VSD is the second most common congenital heart anomaly. We have 4 anatomical types of VSD, as Dr. Hatem and Dr. Soha previously discussed in details. Up to 60% of VSD closes spontaneously, mostly in the first 2 years of life. Clinical presentation of VSDs varies according to the size of the defect and the magnitude of the left to right shunt. Patient with large non-restrictive VSD, if left untreated, they develop pulmonary hypertension, which I said it occurs even earlier in those with Down syndrome. Echocardiography is the gold standard for diagnosis and evaluation of VSD. And as I said, you should have a checklist regarding what is you should answer it before finishing your echo: the type and location of VSDs, the degree of restriction, left ventricular dimensions, pulmonary artery pressure, associated defects and associated lesions. Patients with large non-restrictive VSD should undergo surgical closure within 3 to 6 months. And prophylaxis against infective endocarditis is recommended in all patients with congenital heart disease or with VSD or with left to right shunt. And thank you.
Thank you, Amira.
Thank you, Dr.
Our colleagues keep challenging us by many questions, so
Yes.
we will try to answer them as rapid as we can. The first question is the terminology sausage septum. What does it mean? And for Hatem, what is the option for sausage septum?
So Swiss cheese septum is the septum that has many VSDs, so multiple VSDs. We usually say Swiss cheese septum if there is more VSDs than if there is septum, or technically the VSDs that will not be able to close. This is a difficult issue here because we may try to close as many VSDs as possible and then come out of surgery with probably hard block, very long bypass time with a lot of insult for the heart, and you still have significant unrestricted VSD. This is a bad situation to be in. So the best thing here is to do pulmonary artery banding, so protect the patient from the effect of the high pulmonary flow without physically closing the VSD. This can be his only operation, so live as a palliation like that. Maybe later on continue to a single ventricle repair if the two ventricles are technically not separable. Or maybe we give him the chance for a few years till we find that significant amount of these VSDs have actually closed, and the rest can be closed either by surgery or by cath or even by both. So we can maybe a large device or two can cover a lot of the VSDs, and then with surgery we can close as much as we can, and then we end up with a QPQS less than 1.5, then you have achieved something. But this is a lot of judgment to make.
This will take us for the second question, Hatem. It's pure surgery. When we need to perform a VSD closure and the debanding, if a patient underwent a pulmonary artery banding, when you decide to deband and close the piece.
So yeah, so when is he ready? So
yeah.
there's a lot of judgment here to make, but a simple scenario here is if we have done a band because the patient had multiple VSDs. Obviously we have done a band for a reason. If the only reason was that the patient has a single VSD, but the patient was very sick, I mean, with lots of chest infections, pneumonia, heart failure, we usually wait till the pulmonary artery band should, inshallah, get him out of this. And then we make use of the band. So we let him grow, get him in a better shape, in a bigger size, and then we usually close the VSD by the age of 1 to 2 years. And in the scenario of multiple VSDs, this is a bit different because now when you want to do the band, you have to make sure that the patient is ready to have his ventricles separate. So if there are still multiple VSDs, maybe we're not ready yet. So we'll have to assess very well how many VSDs are there and how are they accessible. So some of them may be closed by cath at first, So maybe if it has a big mid-muscular or apical muscular VSDs in addition to a large perimembranous one or so. So maybe one scenario, one option to do is to close the muscular and the apical VSDs by cath first, and then reassess the cavity, and maybe with the injection of the ventricle, and see how many VSDs are there left. If we have a single or two VSDs that we think are surgically accessible, we then go for that, close the VSD and do the debanding. We do not want to be in a position that we have done the deband, close the VSDs, and we're left with, again, unrestricted VSD. This is, again, not a good scenario. So there is a lot of judgment here, again, usually by the age of 2 to 4 years. But this is very long.
As I'm aware, there is a recent time
to ever do that if the septum is truly Swiss cheese.
Yes. And as I'm aware, nowadays there is a kind of pulmonary artery band that we can solve the problem with the cath, and not we don't have to go back to surgery to deband. Am I right?
One good scenario here is that a patient have multiple VSDs, and then so we did pulmonary artery band. And then most of the VSDs all close spontaneously, or actually the patient got big enough, and the VSDs were closed by a device percutaneously. And now we're left with the pulmonary artery band. So we'll have to do surgery just to do the debanding. Again, not a nice scenario, but some bands can be balloon dilated during the session of the cath. So close the VSDs and dilate the pulmonary artery band. Otherwise, we'll have to do the debanding surgically.
Yes. Are they available in Egypt?
We usually do that technically, so that we do not, we put the band and we do not fix them tightly by either by very fine suture or with just surgical clip that can be blown off, so can be slided.
Clear, thank you. Amira, we have a question for you. How often should you follow a patient with restrictive VSD with no hemodynamic significance by echo or clinically?
Yes, according to the guidelines of congenital heart disease, this patient should be followed at an interval from 2 to 3 years. But sometimes we might be very meticulous. I might follow him up every 1 year, follow him clinically, for him with ECG and with echocardiography. But according to the guidelines, you can follow him up from every 2 to 3 years.
So what are you looking for, Amira? If a patient has a restrictive VSD, a small restrictive VSD, and we've decided that he does not meet an indication for VSD closure, so and you get him once a year or more, what are you looking for?
Yes, maybe the risk of infective endocarditis, as I said, is very low. However, he could develop infective endocarditis. So this is very important. That's why it's very important to follow them up. Not common, but if this VSD became hemodynamically significant and his dimensions start to dilate, so there will be an indication for closure, or maybe his pulmonary artery pressure started to increase or started to raise up. So all the parameters that I discussed in the complete echocardiography, this should be again done in every patient in his follow-up.
Oh, great. So you look for clinical things if any symptoms appear. You look for pulmonary artery pressure, LV dimensions, any history or risk of endocarditis, and obviously if he develops aortic cuff prolapse, because again this can happen later on.
Some types of VSD can develop complete heart block, especially perimembranous VSD, so we might have a check his ECG as well.
Do we have more questions, Dr. Soha? Or there was a question, I think, on the channel, or you just mentioned it to me, if what are the preoperative measurements that we should do for patients with VSD?
Exactly. We have this question, and we have 2 short questions about the MRI. So you can go first for the preoperative non-cardiac surgery and the VSD patients.
Yes.
Yeah, please.
Yes, again, prophylaxis against infective endocarditis is very important preoperative measurement we should do in all patients. And sometimes the patient with Eisenmenger syndrome, actually, this is a totally different story. It differs regarding their hemodynamics, their pulmonary artery pressure, whether they are having severe pulmonary hypertension, what is their oxygen saturation. So this should all be put in concern before any surgical procedure or surgical approach in those patients specifically with Eisenmenger syndrome. Do you have any comment, Dr. Shah? Do you want to add anything?
No, this is perfect. This is clear that non-cardiac surgery, we have to look carefully in the Eisenmenger patient. Otherwise, it mostly goes safe this patient.
Okay,
We have two more questions, short question about the MRI. We have a question about, can MRI detect straddling? Yes, it can, but nobody do the MRI to detect straddling. The resolution of echo or transesophageal echo is much better than MRI. In the second place, it comes the CT with the hazards of radiation, but straddling will not be that clear in MRI. You can have it by chance or if you look carefully, but echo and transesophageal echo, these are the best imaging modalities to answer the straddling.
Yes.
The last question that we have about the QPQS for multiple VSD, can we use it for multiple VSD or only for one defect? This is a good one. MRI can differentiate between multiple shunts in different levels. So actually, if you have an ASD, VSD, and BDA, and you don't know which one play the major or key role in hemodynamic significance, all of them are left to right shunt. So MRI can help in define which level of shunts is more important than the other. But the specific question here about the multiple VSDs, no, the MRI couldn't help. MRI will say that QPQS as a result of VSDs or VSD, it is hemodynamic significant or not. But we couldn't use the MRI for each defect. So if it's the shunt in different levels, yes, MRI can tell you which level is more hemodynamic significant, but in multiple VSDs, you will get the QPQS for the whole bunch of the VSDs. I think that we have all the questions. We cover all the questions, or did I miss something?
Yes.
Yes.
Yeah, we cover all of them.
Actually, thank you all. Thank you, Soha, so much, and Hatem, for moderating this great session. Actually, you did a very big effort together with Amira. Of course, thank you, Amira. You did a very big effort today, and your job was actually absolutely marvelous. You went through the whole topic, although it was beyond 2 hours and 15 minutes, but no one felt bored at all because you were speaking in a very proper pace and a very proper tone, and the data was clearly reaching everyone's mind, also helped by the moderation of Soha and Hatem. Thank you so much. You did a great job
Thank
today.
you, Zara.
I would like to thank all the congenital heart disease team at CEC for attending with us today and contributing to answering all the questions from the YouTube channel. I would like to thank everyone that joined us at the YouTube. Thank you because you are our audience and you always push us to be perfect and to improve our standards. Thank you, CEC board, Ahmed Saeed, Karim Mahmoud, Abdurrahman Gamal, and Haitham Smain. Next Thursday, we have a very interesting session about sudden cardiac death. And next Saturday, we will have a very interesting session about AVSD, common AV canal. So stay tuned and hopefully we'll get to you soon, inshallah.
Thank you, Zahra.
Thank you, Dr.
Thank you,
Soha. I really enjoyed the webinar, and I hope everybody else have enjoyed as with it. Thank you.
Thank you, Dr. Hatem. Thank you, Dr. Shah, for moderating the session, and thank you,
Amir. Thank you.
Bye-bye.
Thank you, Amir.